We'll start by Dr. Professor Tariq Al-Walili. He's a professor of pediatrics from Alexandria University. Then we'll have Dr. Alep Numanoglu. He's the Charles M. Saint Professor and Head of Division of Pediatric Surgery, University of Cape Town, South Africa. Then we'll have Dr. Juan Carlos D'Agustin. He's the WOFAPS President-elect, and he's the President of the Spanish Association of Pediatric Surgeons. He's the Chair of Pediatric Surgery at the University of Materno-Infantil, Universitario Gregorio Marañón in Madrid, Spain. Finally, we'll have my distinguished friend, Dr. Ayman Al-Baghdadi. He's a professor of pediatric surgery from Ain Shams University.
Okay.
So if you talk about Alexandria, our home city, it's a well-known city of civilization. And this report in the National Geographic gives it the advantage of being the first city that affecting the civilization, the first millennium. As you see in this picture, you can see the doctor, the physician, just in front of the Minaret Alexandria in the Bibliotheca of Alexandria. Just a pediatrician dealing with the child and his assistant preparing the medication. The pediatrician was a pharmacist at the same time. Talking about today is necrotizing enterocolitis. That's the controversies and the challenge of the practical, especially those dealing with the newborns. By definition, necrotizing enterocolitis is an inflammatory intestinal disorder primarily seen in premature infants, characterized by variable damage of the intestinal tract, ranging from just mucosal injury to the full thickness and necrosis and the perforation of the gut. It's not a new disease. It's well known since the late 19th century, but it's distinguished pathologically since 1952 by Schmidt and Kaiser, who is entitled pathologically as enterocolitis ulcerosa necrotitis. From this time, it's well known as a disease and started to search for, especially in the early 60s, that well known for many people to study. And as you see in this diagram, we can see the progress of number of researchers. We are now in the 21st century, but it's still a controversy persists with regards to the most appropriate management in neonates and necrotizing enterocolitis. Talking about the spectrum of the disease itself and the epidemiological data concerning it, it's nearly affecting 10% of this preterm, especially those less than 1,500 grams. The mortality rate is a little bit high, especially in those extremely low birth weight, less than 1,000 grams. It's approximately 30 to 50% of patients that are affected. But in the very low birth weight, who is less than 1,500 grams, it's about 10 to 30. This category is not changed a lot along these past years. Talking about the gestational age, it occurs in many diseases according to the healthcare these neonates, but with the gestational age, those less than 24 each week of the gestation, it is 2% in Japan and up to 9% in Australia, Canada, and Italy. But those with gestational age from 28 to 31 weeks, it's a little bit less, especially in Japan, 0.2, so there's a tenth of the number before, and in some other countries, it ranges from 2 to 3%. For the very low birth weight infants, the incidence here as a morbidity, it's 200 in Japan, 2% in Japan, 6 to 7% in USA, and more in 900 in Poland. The same for male and the females. No distinction between the two categories. It's either many factors affecting the occurrence of the disease, especially those even started during the pregnancy. Those maternal type of microbiota, the maternal status and nutrition, the lifestyle, the intake of or abuse of drugs, even the antibiotic exposure for the mother, and with some genetic predisposition to the disease. At birth, it depends upon the gestational age. Of course, it's much more incidence in the premature due to intestinal immaturity. Sometimes the delivery way between the normal delivery and cesarean are affected, and antibiotic exposure to the newborn. For the infancy, the feeding type, who doses will start artificial formula early, especially those with hyperosmolar type of formula, will be affected, those with antibiotic exposure or affecting medications that affect the intestinal acidity may be affected. So there is risk factor, especially those with very low birth weight, for the prematurity, inadequate perfusion of the gut mucosa and the immature mucosa, aggressive advancement of the internal feeding, especially those with formula with hyperosmolar type, subtraction of solution, especially medications as antacids and antibiotics, bacterial overgrowth in this condition. So this is an overlap of different types of risk factor for this patient, this disease, for the prematurity, for the opportunistic bacteria, and less than the commensal types, for the gut dysbiosis and the imbalance between the both types of bacteria inside the gut of the microbiota, the antibiotic exposure, the type of formula, and of course the excessive inflammatory response with the altered mechanisms. So we have the day of premature is 17 November. So we had to take care of those who were born too soon before time, because there is susceptibility of the preterm infants for necrotizing enterocolitis at the type of the immature gut, especially the immature mucosal immune system, with reduced proteolytic enzymes, decreased peristaltic movement of the gut, with altered epithelial membrane and the acting of the tight junction in between the cells of the gut that allow invasion by type of bacteria and cause an imbalance between the different types of bacteria and altered bacterial flora, with decreased mucus production and the mucus coat, and intestinal epithelial susceptibility, which cause direct invasion of the bacteria and start the inflammatory action. Using the breast milk course will be helpful in this condition, because the breast milk with its human milk oligosaccharides will help in the process of maturation of the gut. So the given to the baby.
Do we have a problem with Dr. Tariq?
Yes, looks like there is a problem with the connection. We are waiting for him to be back.
He could not be aware of it. Maybe someone should text him.
Dr. Samah, can we text him, please?
Yes, please, sure.
Yes. Dr. Tariq is back, I think.
Okay.
Human milk oligosaccharides. This type of substance in the human milk that enhance the growth of the gut of the
screen is not shared.
Dr. Tariq, can you please share your screen again?
Okay, that's just a minute. Okay?
Yes.
Let's return back.
Yeah.
That's right.
Yeah. Good.
Give me a second to prepare it again. Yes, that's right. So the intrahuman bacteria disrupt invade the intestinal epithelium with the intestinal villi, and those they stimulate the toll-like receptors that's secreted on the surface of the gut and start the immunologic reaction and facilitate the breakdown of the gut barrier. Those types of TLR or receptors that are responsible for the homeostasis of intestinal surface and helping the response to injury and the process of regeneration of the intestinal cells. As soon as this intense inflammatory action occurs in the lamina propria with a vasoactive substance release, this intestinal inflammatory action activates the complement and the coagulation process and enhance the tissue injury of the intestinal wall. So it starts by all in favor of the pathogenic bacteria, some sort of genetic predisposition affecting the TLRS4, and immature intestinal barrier with decreased mucosa, decreased IgA with low intracellular junction integrity, allowing the inflammatory action to be exaggerated through the inflammatory mediators, and of course the result will be intestinal necrosis. Some factors involved in this pathophysiology, especially those with nitric oxide release, which acting with other substances inside the gut to form peroxynitrite, which is a potent oxidant that stimulates the inflammatory process, and the imbalance between the tissue damage and tissue repair will catalyze this inflammatory process to the maximum. And with toll-like receptors, those receptors, especially the preterm baby with high expression, so this stimulates the intestinal epithelium, and in the period of the injury, it's more impaired, so the intestinal regeneration of the cells will be enhanced with high apoptosis, with more death of the intestinal cells, with less migration or proliferation of the intestinal cells to compensate for the damage that occurs. There is a type of macrovascular blood flow because it's intestinal ischemia at that particular time, with insufficient blood flow to the intestinal wall. With this type of disarrangement, it will help facilitate the inflammatory cascade to get fastly and resulting in intestinal injury. Of course, the microbiota, when that occurs, the imbalance between the active part of the commensals or responsible for the growth of the intestinal wall. This type of dysbiosis is a disruption of gut microbiota between the type of commensal microbiomes and the pathological bacteria. And this dysbiosis occurs frequently, especially with those on use of antibiotics or antacid during the NICUs, of the formula feeding with hydroosmolar type, and of course with those with inflammatory response dysregulation. Lastly, the intestinal stem cells, those are very responsible for regeneration and producing progenitor cells of intestinal wall. These different types of enterocytes responsible for the secretion of absorption, goblets responsible for the secretions, enteroendocrine cells responsible for the homeostasis inside the gut. Clinically, as pediatrician, we can see the patient, especially those who are preterm, very shortly after birth, within few days, with dull, dusky colored distended abdomen, with apparent symptoms and signs of sepsis, temperature instability, poor perfusion, lethargy, large abdominal distension, with bilious vomiting, blood in stools, hypoactive and absent bowel sounds by auscultation, and later on abdominal distance. So if it's continued the same process with the progress of sepsis-like syndrome, we start mottled gray skin with capillary fill delay, apneic spells, bradycardia, abdominal tenderness, edema all over. Sometimes it's flare around the umbilicus, as we see in such pictures, with mottled skin, with gangrene, even the abdominal wall, marked distension, dilated blood vessels. Side, which is characteristic by the presence of nematosis. Nematosis is essentially to occur with the progress of the process of, especially in submucosal or subserosal level. Lab signs, if we took for initial workup, of course, the complete blood picture we show thrombocytopenia, neutropenia, or poor progress of the white blood cells, with disseminated endovascular coagulopathy DIC panel with elevated BT and ENR, BTT, the dimer, and decreased fibrinogen product. For the metabolic basic panel, we can see hyponatremia, hyperglycemia, and of course, the blood gases will shift towards metabolic acidosis. We have to proceed during blood culture to see if it is occult affection or not. Later on, thrombocytopenia raised the C-reactive protein, pneumoperitoneum, collapsed ventilation, and the need for ventilation. For the imaging, the plain X-ray is the cornerstone of the process. It is very diagnostic, pathognomonic, especially with that, with nematosis intestinalis. With the severe form progressed conditions, we can face by ascites, venous affection, or pneumoperitoneum with intestinal perforation. You see in this trace, we can
Dr. Tariq, we still have him? Is Dr. Tariq disconnected again?
Yes, I guess. Can I take this opportunity to ask the participants to keep the chat in English in order for us to get the questions to the speakers?
Oh, we have Dr. Tariq.
Surrounding dilated bowel loops and free fluid in the abdominal cavity. This type of necrotizing enterocolitis in a standing position with necrosis intestinalis, dilated loops usually, and the static loops because it's not changed due to no intestinal motility. So we can see if it's repeated, we can see the same loops in a static position. Pneumoperitoneum occurs after perforation in these conditions, and we can see the air loops, especially those around the liver, above the liver, and the football sign, which is the air or a gas on either side of the falciform ligament of the liver. In the case of male, sometimes it occurs with pneumoperitoneum up to the scrotal sacs. So there's different types of pneumatosis intestinalis, portal vein air, and pneumoperitoneum with the football sign. Ultrasound would be helpful, especially those with Doppler ultrasonography, because it is very mandatory to give a chance to see the necrotizing enterocolitis effect on the bowel viability. There is a special type of near-infrared spectrophotography, which is very essential for this condition to measure the local tissue oxygenation of the gut. This condition of Doppler study affecting the intestinal wall, we can see that the normal with sparsity of the blood vessels, much congestion occurs in that with intestinal affection with necrotizing enterocolitis, with dilated loops and thin dilated numberstalsis. Necrotizing enterocolitis and intestinal gangrene and the perforation. For the staging of this process, either according to the severity of the disease itself, because we can take either suspected condition with lethargy, apnea, bradycardia, temperature instability, with some blood in stool, but there is no X-ray appearance. With more severe condition, there is absent bowel sounds, abdominal tenderness, or cellulitis in the wall, but X-ray start to show pneumatosis intestinalis. In the very severe forms of the mandatory for surgery, with affection with peritonitis and perforation, of course, with severe hypotonia, acidosis, disseminated intravascular coagulopathy or DIC, neutropenia, the X-ray show ascites, portal venous air, and the pneumoperitoneum. According to the stagings modified or Bell modified staging that occurs in 1969, it starts the classification as early as the 70s, but the classified or the modified part depending on the severity, 1, 2, 3, and each one subclassified into A and B. With those with suspected condition, the staging A, just that we say not severe, it is just a suspected condition with normal X-ray better, just intestinal dilatation, no ileus or mild ileus. For the
Dr. Tariq, we have 2 minutes.
Okay, that's all right. So it's what to do for the statistics, treatment strategies, prevention, treatment, surgical, and the future. Of course, for prevention, breast milk is the mandatory introduction of breast milk products and the probiotics in the breast milk. So with evidence of efficacy and safety, breast milk and non-aggressive enterocolite. For the medical part of treatment, either suspected or confirmed X-ray without complications, no need for operative procedures. We go through withholding of feeds, ventilatory support, fluid restriction, inotropic support, correction of acid-base balance, coagulopathy, thrombocytopenia in case of that, and bowel rest and the antibiotics. For the intake and the antibiotic according to the guidelines, especially for those suspected to have necrotizing enterocolitis in stage 1A or B, we get started with neficillin or gentamicin, give suspected domiciliary resistant Staph aureus or those with the history in the nursery with domiciliary Staph aureus. If it is suspected to be definitive stage 2 or 3, with non-operative one, we can start, it depends on renal function. If in renal function, we give bracillin with tazobactam. With those with intact renal function, we start by ampicillin, gentamicin. If not respondable, we add metronidazole. The duration of intake of antibiotics, depending upon the clinical part, up to 7 to 10 days, or 3 to 5 days after complete recovery. And this also stay with holding fees through the gut. For the surgical intervention, this with requirements of inotropes, worsening abdominal findings, hemodynamic instability, worsening the laboratory findings, especially those with stable doses, with distant thrombocytopenia or leukocytosis. Those with ultrasonographic evidence of decreased or absent bowel perfusion is mandatory for surgery. For the future potential therapy, it is breast milk components, especially those with human milk oligosaccharides already manufactured in some companies now. Prophylactic probiotics, which given a chance by American Academy of Pediatrics to be prophylactic, especially for growth preterm. The future or the hope for stem cell administration due to the amniotic flow into stem cells given intraperitoneal injection, and this occurs in lab for the mice, and it's successful up to now, and it's helped to promote the regeneration of the intestinal epithelium. Thanks a lot. I hope I can not talk too much. And that's Alexandria.
Very much,
I hope
Dr.
you
Torre.
next time to see Alexandria live from sunrise to sunset. Thanks a lot.
Thank you very much, Dr. Torre.
Next, we'll go to the surgical part. Now we have listened to the medical side. You know, NEC is a disease that combines the efforts of surgeons and pediatricians, and there is a golden hour of when the surgeon should go. And this is what we're trying to reach today. The next part from surgery will be by Alp Numanoglu, who is the coming president of WOFAPS, the WOFAPS president-elect. Alp, please go ahead.
Thank you very much, colleagues. And firstly, I'd like to thank the Egyptian Society for the very kind invitation. And it's really a great privilege and honor for me to be with you today. And COVID-19 has impacted us tremendously globally and also in Cape Town. But I think if we can say that there was one benefit of COVID, it's to use the online methods and bring us together. It's wonderful to see so many people together today. So I've been asked to talk about the peritoneal drains, drainage, and stomas. I'll predominantly be talking about the peritoneal drains, use of them in necrotizing enterocolitis, and I have a few slides on stomas. As we've heard, the NEC can be managed by two ways, the medical way and the surgical way. Surgery comes into play when there are complications related to necrotizing enterocolitis, or if the medical treatment appears to fail. We've also heard about the Bell's or modified Bell's classification. So the two groups here, the grade 2 and grade 3, or the definite 1 and the advanced 1, are the two groups that surgery is usually got a role to play. Grade 1 is usually managed by medical treatment. There's perhaps an area for laparoscopy. It's not something that I will be talking on, but one can discuss this further perhaps in the discussion. Indications for surgery, difficult to say in certain circumstances. There's no clear guidelines available in terms of indications, but there are a few, like in the free air or pneumoperitoneum. This is a definite indication for surgery or surgical intervention, one way or the other way. And then there's a list of other things that I've got here, like portal gas or fixed dilated loops. Some surgeons would regard them as indications for surgery, but some may just use them as a tool towards making a decision. And then there's the others that has a lesser impact in a way as a single identity to make the decision on whether to perform anything surgical or not. So I do have a poll here now. If I can perhaps have the poll coming up, and let's see what the practice, in your practice, if you can tell us whether you're using peritoneal drainage or not. Peritoneal drainage, I'll talk a little later, but either as a way of inserting a drain or putting a intravenous cannula into that. So we can see there are about almost 200 people replied, and majority, close to 90%, are saying we are using peritoneal drainage. That's very nice. So at least it gives us an indication of the audience and what our practice here. Thank you very much. If you can just now close the poll. So in terms of surgical options, we have quite a variety of things that we can choose from. As I mentioned, the peritoneal drainage is something I'll be talking on, but this can be with or without the use of laparotomy. And then the others is resection, doing a stoma, doing a primary anastomosis, the damage control one, and you can see on the slides here of a child who's had a damage control with abdominal wall left open with a vacuum dressing on, and a relook following that, or a defunctioning jejunostomy. A number of options that is available to the surgeon. When the decision is made, the factors that are impacting is the size of the infant. Size of the infant is such that local conditions also play a role in resource-limited areas, and South Africa is certainly one of them. One may make the decision that the smaller the infant, the less one would do. Our neonatal units have reached to a stage where they had to define at a certain time that the very small birth weight children are not referred to us for surgery. So size is certainly making an impact in our decision making. And certainly the degree of metabolic derangement, how sick the baby is or how fit the baby is for surgery will impact on decision making, as well as the extent of the disease that's obviously available to us when we do the laparotomy. So let's go to the peritoneal drainage again. And it was in 1990s where Sigmund Ain, Barry Shandling, and a number of other pediatric surgeons published an article where peritoneal drainage in certain circumstances or in certain cases, and in their series up to 32% of their patients, was all that was needed. So they didn't have to do a laparotomy to follow the peritoneal drainage, and that was enough for the treatment of the baby. So that's an interesting concept. It's obviously something that made many pediatric surgeons quite excited about and think about using peritoneal drainage more extensively with an added tool to the management, and also with potential that it has shown in that study. When we talk about drainage, we are often called to the neonatal ICUs, and with a child who has potential pneumoperitoneum with ventilatory difficulties, distended abdomen, use a little bit of local anesthetic, and we often put a small amount of adrenaline in it as well, because they often have bleeding tendency at that stage. And we insert drains on both sides, in the right iliac fossa and left iliac fossa, with a small incision with the mosquito, almost like putting a chest drain in, and one goes through the abdominal wall, reach the peritoneal cavity and deflate the abdomen. And then you can use different types of drains. One of them is a pencil drain, like we're seeing in the picture here, or you can simply use a glove, a finger of a glove, which is also acting as a very well drain. The other thing that we often use is the urine collection bags. They function excellent as stoma bags. They have an adhesive already attached to them, and they can be applied very simply. They obviously don't have the outlet. It's not for drainage of anything, but it contains the effluent fluid very well, and it's clear color that one can see what is collecting there. So going back to the surgical management, as we've also heard from our first speaker, from the professor, that about 30 to 50% of NEC cases require surgery, and it has a high mortality rate and very high morbidity rate. The one thing is that the management is, there's no uniform management protocol that is applied in different countries, and not in different institutions, and definitely even in one city, even in Cape Town, in different institutions, we have slightly different management protocols. The use of peritoneal drainage has been investigated in a randomized fashion in 2 studies. They go back to 2006 and 2008, so it's quite a few years now. They had reasonable number of infants, 117 in one study and 69 in the other study. Looking at it, there was slightly different management protocols applied in studies. One had quite significantly high laparotomy rate following the peritoneal drainage. But at the end of it, none of these studies, neither of them actually showed any significant difference when they compared the peritoneal drainage with the laparotomy groups. And then a further Cochrane review also supported this. So there was no conclusive outcome where the peritoneal drainage is really making a significant difference in the outcome. A couple of other things that we need to keep in mind. Surgical NECs are often associated with long-term neurodevelopment impairments. And in the absence of clear results from different institutions or different regions, there's definitely a need to have a multi-center collaborative studies. The outcome is based on a number of things, as we've also highlighted before. And I just want to tell you a few things about a small audit that we've done. You can see the Red Cross Hospital is here for the few perhaps lucky ones who had the opportunity before COVID-19 hit us, come to Cape Town. And so Cape Town, you must have seen the big mountain in the middle here. So we service Somerset Hospital, GSH and Mowbray Hospitals. These are the 3 big maternity units with the neonatal units. And the surgery takes place at the Red Cross Hospital, which is where the pediatric surgical services are. So we don't offer surgery at the 3 maternity units, but the patient needs to come to us. So that's the setting that we are in. And we use the peritoneal drainage as part of the resuscitation. And it's done at the intensive care units where the patient is referred to us. And it's predominantly to improve the ventilation and drain the effluent fluid from the weight of the baby also plays a significant role. Certainly the smaller the baby, perhaps the better the impact of it. We've seen these pneumoperitoneums. We've talked about the weight. It's something that is minimal surgical impact, really. There's hardly any blood loss. And it sort of allows perhaps for the demarcation to take place when the bowel is compromised, because when we get to surgery, after having given some time to the child with a peritoneal drainage, the compromised bowel is better visualized. And from our point of view, certainly it helps with the transport of the baby to our center. In terms of the different types of drains, we would put bilateral drains, but a single drain, if there's going to be single in the right ileal fossa, would be an ideal one. The irrigation is something that we haven't really practiced, but in a number of babies where peritoneal dialysis was also required, they seem to have benefited from this irrigation, but it's certainly anecdotal and not based on any science. And if no surgical facilities is available, just inserting an IV cannula is also adequate. In addition to the pencil drains and the gloves, if one has access to the blade drains, that also works well. So in the audit that we've done, this is not a scientific study that's published, but just our practice we looked at a number of years ago over a period of 2 years. And we had 30 patients referred to us from these 3 hospitals. And here you can see the parameters belonging to these patients, and certainly the drains were used in the group where the patients were sicker, where the base excess was -10, where the pH considerably lower than the other groups. And the ones who were slightly better in shape required the drains, or they were put in drains and then transferred to us for laparotomy. The group who was in a much better shape could come across without the need for the drain and have the surgery done. And there was a small group of people, there was a small group of patients that we treated conservatively, meaning at the referring center. And this is the results out of the 30 patients. The group had drains only, the sick ones, all of them died. The groups had the drains and laparotomy, bigger babies compared to the previous group, about 50% survival they had. The laparotomy group, which was the better group in terms of their presentation, did better in outcome as well. And the conservative group, this is mainly the sort of in-between cases where it was medical NEC, but they called a surgeon, and we advised them and also did well. So when we don't have clear outcomes and clear studies to guide us, it's also nice to see what the perception is and what the other surgeons are doing. And this is a study from United States, quite a large number of infants, about 36,000 of them, about 8% developed NEC. And in that group over a 12-year period, they have noticed both in the medically treated NEC and in the surgically treated NEC a decrease in the mortality rates, as well as a decrease in the number of NECs seen. So they looked at what percentage of the babies they had peritoneal drainage, and over a period of 12 years, they have found that the use of peritoneal drains doubled from 23% to 47.3%. So more surgeons are using drains and more patients are receiving drains. This is in the background of that studies, randomized studies, showing that there's perhaps no difference in the use of peritoneal drainage. The mortality has decreased over that 12-year period in that large series, but the decrease was not just in the peritoneal drainage group or the laparotomy group, also in the medical group. So that implies the better care of these infants in the neonatal ICU. Very briefly, my last couple of slides. In terms of use of stoma, the stricture rate is something that's always in my mind, and the concern of doing primary anastomosis with an ongoing disease and the potential stricture formation with other complications. So I think if we group surgeons into the ones who are more prone to primary surgery or the ones who are prone to stoma therapy or stoma being utilized, I would be on the stoma group perhaps, but let's see what the other surgeons are doing. So if you look at the studies, certainly people are performing primary anastomosis for lower risk patients quite a lot these days. And this is used in the cases where there's focal disease, where the infant is bigger in size. Instead of using a stoma, a primary anastomosis is preferred. And but again, it's really up to the surgeon to make that decision. The early complications that we're very much aware of are the strictures, the abscess formation, the hissence of the wound, and the recurrence disease is what is in our minds when we think about doing the stoma. And again, I've got another poll here. I won't be talking too much around the way to bring the stoma out, but if we can ask you, do you bring the stoma out through the laparotomy wound when you do NEC laparotomies? Or do you bring it out from a separate wound? For many years, it's been our practice to bring the stoma through the laparotomy wound. And we've sort of shifted in a way in certain cases now to bring it out as a separate incision. And I think we can see almost half of the attendees that indicated their choice. Our majority of them are indicating that they bring it out from a separate site, about 80% to 20%. That's very nice. So thank you very much. Let's end the poll here. I will just close the poll for me as well. So if a stoma is performed, obviously, firstly, we want to make sure before closing the stoma that there is no distal stricture, and that's done through a contrast enema. And it's usually done at about 6 weeks after the stoma is performed, after the index laparotomy being performed. So
Professor Alep, we have 1 minute.
this is my last slide. I'll finish before my time ends. And unfortunately, there are many controversies, and we don't have clear answers to many of them. Thanks very much.
Thank you, Professor Numanoglu, for this lovely presentation. And it was very illuminating. I think right now we will have a Professor D'Agostino.
Yes. Juan?
Yes, please, Juan.
Hello?
Hello,
Yeah.
Professor.
We can hear you.
Okay.
Yeah.
I would like to thank you the invitation to be here and to be part of the faculty today and to do this talk in memoriam of our great friend, Professor Hessam El-Saket. Well, after Professor Numanoglu, I would like to talk about something about resection and anastomosis, second look, back therapy and laparoscopy. So I would like to address and to answer these questions. If resection and anastomosis has to be done and when, is second look relevant still in modern era? The back therapy now is a new trend to treat complications, mainly complications in the NIC, and something about laparoscopy in NIC. So first of all, I'd like to mention that in the second volume of the Journal of Pediatric Surgery in the year 1967, Tulukian and Santulli stated what is still very valid, that to do a laparotomy and enterostomy, it's probably the safest way to preserve the bowel and to have a better survival. But in the last 20 years, there has been a lot of things about regarding to the primary anastomosis. So this is my first question. In which of the following circumstances you will do a resection and anastomosis in the patient with NEC? I do never do, or only when the distal bowel is viable and in stable patient, on when there is only one resection, or whether it's still a clear margin in the necrotic area. So in the poll, we can see that the answer number 2 is winning. So I will answer that at the end of this part of the topic. Okay, so we can close the poll. So first, we have to consider the extension of the disease. Not every patient has the same prognosis. So we can identify the isolated or the multifocal or panintestinal lesion of the bowel. So if we can identify with this extension of the findings of the necrotic finding, we can perform resection and anastomosis as described by Piero et al. In 2003. We can see here that not in the most severe affected patients are attempted to do any kind of resection. It's just when the patient is stable and there is a viable distal bowel, they perform and recommend to do primary anastomosis. So there is in the literature some evidence in favor. Like you can see in this slide, there is a high survival rate when there is a primary anastomosis in this work. In another, they found a low morbidity and mortality rate or better recovery. And there is a little more survival, almost double survival when is done anastomosis, primary anastomosis, than when resected anastomy in this group. And there are some other authors that have similar results. But against, there are also some evidence. There is some works that proves that there is a higher survival when ostomy is done, or there is no different survival rates, or there is a high incidence of stenosis after the surgery. Although we know that the structures is a high finding, is very frequent in all NEC series. So probably if we have to choose any patient that has to be elected to do an anastomosis, a primary anastomosis, he must be hemodynamically stable, has a focal or multifocal disease with distal viable bowel, and we have to do a resection and anastomosis when the disease is limited and there is no high contamination or severe disease. So we are more prone to answer this question as everybody that did at the poll. So we are talking about second look. And this is the second question. Which statement is true regarding to second look operation in NEC? The huge evidence in the literature supports second look operation. It's advisable when extensive NEC is detected. Aggressive second look laparotomy does not improve survival. After peritoneal drainage, the second look operation is not necessary. So we can see right now that number 2 is the preferred answer in between our people here. So we are finished the poll and follow the presentation. So I wanted to see what is in the literature review, and I was looking in PubMed last week, looking for NEC and second look laparotomy. There were only 18 articles. 5 of them were not focused on NIC, and only 3 were dedicated to the second look itself. This is the number of articles in the last few years. So this is the first article that was published in 1980. The first intervention was drainage. There was a 46% of survival. And they found in the second look operation that 4 had intact gastrointestinal tract. There were only 7 survivors. So the conclusion was that drainage is effective in temporizing the very ill neonate with NIC. You can see that there were small babies as well, but this is a huge range of weight in these patients. We did another study in our institution that was published in the Spanish literature that doing also drainage as a first step in this is there were 30 neonates. In 10 of them we did drainage and laparotomy as a second look. After the drainage there were 8 survivals, and after laparotomy as a second look at the end there were only 3 survivals. So at the end was a 37% of survival in these patients. They were very sick and very extremely low birth weight babies. You can see here there were less than 900 grams. This is the second article published in 1986, so they were quite old, but there are quite a few, as you can see here. There were 14 second look laparotomies out of 32 NIC patients, and they were done in between 24-36 hours after the operation. And they found a survival of 71% with second look and only 66% without second look laparotomy. And at the second look laparotomy, in these 10 patients, they found 2 perforations. And so they conclude that aggressive second look laparotomy can improve survival in the critically ill neonate. And the other work was more recent in 2015. There were only 6 patients out of 34 NIC patients. The indication for second look was doubtful bowel viability and physiological instability. And they found a survival of 5 out of 6, so very high, 83%. They were babies also in a wide range of weight. You can see here 580 to 2,080 grams. So they conclude that this is a viable approach for extensive NIC. And this is whole series together. So already published, centered in second look, we can find that almost around 50% of survival it's already get with this. And looking at another survey that EPSA did in 2015, we can find that there is a substantial number of people that answered that they do second look operation. Almost 43% of them, they did a second look laparotomy. Although this is a technique that we use I think in every hospital around the world, there is no good or recent works centered on this. So probably we can conclude at second look that it can be done after peritoneal drainage or first laparotomy. We can do it in panintestinal and NIC when we have a doubtful bowel viability and we want to come back 24, 48 hours later to see if we can save more bowel. In cases that there are physiological instability or as a damage control strategy. And talking about damage control, there is an interesting work very recently from the last year that there were 23 patients with NIC, and they had a high survival rate when treated very conservatively when closing the abdomen. And this is some picture of the work using vacuum therapy as a measure to treat these catastrophes. This is one of our patients that were treated in this manner. We have treated several ones of these, and it's a great tool to treat with these difficult managing patients. This already had an enterostomy in the center of the bowel, and we have to manage in this way to put to do a very ingenious way of drainage and to apply the vac therapy around the stomach. So the answer to the question is regarding, as you said, when the NIC is extensive. So we have the last one, the last question about laparoscopy. Laparoscopy is definitely contraindicated in NIC. 30% do not require further surgery after laparoscopy. 80% needs further surgery. Or the last one, that 20% of pediatric surgeons around the world are doing this aspiration in stable patients. Okay, we can see that most of the people are centering to the last one. 53% of people answer and 25% is contraindicated. Okay, we are going to talk about that. We can stop the poll. Thank you. So I also wanted to see what was going on in the literature, and I found that there were only 19 articles, 6 original, 5 reviews, and 8 unrelated. So now there is quite a few evidence in the literature. So the first suggestion about applying laparotomy or laparoscopy in NIC came from Professor Moore in UCLA in United States in the year 2000. Rothenberg showed us that neonatal laparoscopy is feasible, especially if we want to do intestinal mobilization or to do even resection and anastomosis extracorporeally or intracorporeally as well. And in IIC, it could be a valid option. And the first work came from Professor Piero and team in 2004. He studied 11 neonates with suspected NIC, 9 had NIC, 2 were excluded. They found non-perforated, perforated, and gangrenous NIC, and so they could select some patients for draining or immediate surgery. 2 had no more surgery done, or they in this branch, and 1 laparotomy. There was no surgery done in this one, and delayed laparotomy. So this is the experience. Another case was published by Professor Clark in 2006 in 1 small baby. There was another work from the Tan and group in also more recently about 4 patients, weight in between 500 and 1,000 grams. And they found 1 normal bowel and 3 perforations, and they did micro laparotomy and stoma. So another case series from Italy, from Leva, Ernesto Leva. They did 8 newborns without applying any pressure, intraperitoneal pressure. 3 were small babies, and they found 6 perforations and converted, and 2 has diffuse neck and drain and all survived. So it's a great result. So Martinez Ferro also in post-neck patients, they did some extracorporeal or intracorporeal resection and anastomosis, but this not in the sick period of the NIC. And there was also some evidence published in 2011 in 3 extremely low birth patients and 1 larger patient, using very small trocar to localize the perforation and to do the stoma using the laparoscopy approach. Also from Cape Town, Professor Numanoglu, that is here with us, and Professor Miller, published a series using fluorescein to detect the necrotic area of the bowel, and they could confirm the findings in the laparoscopy, and they had only 2 out of 13 patients died. Our experience in my hospital was we did a study in 2011, and our criteria to do some consecutive patients in laparoscopy exploration was suspicion of NEC without radiological evidence, so it's a very doubtful diagnosis, or NEC not responding to medical therapy and no clear criteria for laparotomy. We studied the tolerance of laparoscopy during the operation, studying the CO2, respiratory CO2. There was no difference along the operation, or respiratory per minute, or oxygen concentration or the peak inspiratory pressure. There was no difference along the operation, so the patients were stable. There were 10 patients with a median age of 13 days and weighing 1.1 kilo. This is radiographs that were very doubtful, and this is the technique. Telescope, it was 3 or 5 millimeters, was the camera sites in the 10 patients, and the pressure in the abdominal cavity between 6 and 10 on one patient, 10. And the finding was one unaffected, and only we did wash and drain. There were 3 patients that we detected gastric pneumatosis and did a gastrostomy, 1 necrotic loop and mini laparotomy. We confirmed that diagnosis and do resection and ileostomy, and 1 ischemic second that was done a ileostomy by mini laparotomy. There were 4 more patients with resection and ileostomy. The findings by laparoscopy were mostly fluid stained by fecal material or turbid ascites. We found a necrotic loop also, and 1 fecal staining fluid, and a jejunal perforation, so it was resection and jejunostomy, and 2 ileal lesions that were resection and ileostomy. And 2 more patients that only was found purulent material and was wash and drain in both patients. So at the end, from 10 patients, there was 3 wash and drain, 1 resection and jejunostomy, 4 resection and ileostomy, 1 ileostomy, and 1 gastrostomy. So we found that it was useful in this difficult diagnosis in these patients, and it was done at the bedside in the NICU. So at the end, and we are finishing the presentation now, there is a summary of the laparoscopic articles already published, including ours, that was published in 2013, and after that there were no more reviews. So we can see here that there were a laparoscopic standard with gas in 28 cases, gasless in 8 cases, and fluorescein in 8 cases. There were almost 20% of infants did not require further surgery because they had no evidence of NEC, or they had no evidence of perforation or intestinal gangrene, or had a panintestinal NEC that preclude further surgery. But 80% needed further procedure, and most of them were stoma formation, and only 9 peritoneal drain and 7 intestinal anastomosis. The mortality rate was around 14%. 2 was care was withdrawn, 2 died of ongoing NEC, and 2 recurrent NEC following recovery. So at the end, we can conclude that selection of the patient is very important. And for us, NEC without radiological evidence can support laparoscopic exploration or not responding to medical therapy. The same questionnaire used by the EPSA, they only found that 8% of the people use laparoscopy. So at the end, the question 3 is that this is the true one. 80% needs further procedures. Almost 20% do not require any further procedure. We can find some indication for NEC, especially in doubtful diagnosis. and only 8% of pediatric surgeons are doing this exploration. So probably the future is neither of these techniques. Probably the future is, as we were seen by Professor Walili, is that prevention is the future. And thank you very much, and I hope you stay safe, and for sure we will stop the virus. Thank you.
Thank you, Professor D'Agostino. Now we have Professor Ayman Al-Baghdadi from Ain Shams University. He's my dear friend. Thank you very much. Will you please go on, Professor Ayman?
Is it obvious now or not yet, Khalid?
Yes, yes, we were seeing
Yes.
your...
Okay. Okay. Assalamu alaikum. Hello, everybody. Happy feast for Muslim colleagues. You can see after Dr. Walili and Dr. Alba and Dr. Augustine, I think my talk will be a revision of all of discussions or all of things you hear from others. So necrotizing enterocolitis, as you see, is a disease of preterm infants, and it is, we can say this, it is the taxes that we have to pay for advancement in the technology and in saving preterm infants. So we are saving, but they are developing NEC. And it is very drastic disease and very destructive with high morbidity, high mortality, and very costly for NICUs. And that's why we have so many studies. As you see, Dr. Augustine mentioned a lot of studies, but there is little progress, as Dr. Walili said, because it is there is an advancement in everything, but we cannot prevent, we cannot treat, we don't know the exact histopathology and the pathophysiology of this disease. That's why also we are using a classification done by Bell in 1978 with a lot of modifications, because we don't know the exact pathology, the exact way of management of this disease. As Dr. Walili said, it occurs in 1 to 3 in 1,000 births, and it is a disease of low birth weight babies, but it occurs in about 10% of cases of full-term babies, especially who have been subjected to umbilical catheter insertion or congenital heart disease like Patent ductus arteriosus, or they develop Hirschsprung disease, or intestinal atresia, or any cause of neonatal stress or neonatal asphyxia. So full-term babies develop also, as I said, in 10% of cases, NICU. No sex predilection, and it can occur in all the races, and we have a lot of risk factors. Actually, the most important is the prematurity, and as Dr. Tariq explained everything in this area, and there is also aggressive and advancement of enteral feeding, because mothers all the time trying to feed their babies because they need the baby to grow and grow and grow and so on. And usually the enteral feedings, the artificial feeding are giving are hyperosmolar. And there is also the preparation of this artificial milk mostly get contaminated by bacteria. That's why they have bacterial overgrowth. As you see, the risk factors. In our country, as you know, we have a lot of deliveries outside the hospitals. That's why incidence of infection very high. And there is no proper antenatal care, of course, in all babies. The first question is, Dr. Tamir, can you follow me in this? Okay, first question. No single specific cause has been discovered for NEC. All of the following factors nevertheless have been implicated in its pathogenesis, except selective circulatory ischemia, the diving reflex, or immature barrier, or bacterial colonization, breaks in isolation technique by nursery personnel, or intestinal ischemia in utero? As you see, 44% or around 45%, choice E. Of course, antenatal ischemia doesn't interfere with the pathology of the baby as regard NEC. Pull out if you please. Pathophysiology, as Dr. Tariq said, a lot of mechanisms sharing the pathophysiology of. There is something wrong in my presentation. Hello. Khalid.
You can click on the presentation slide, Dr. Ayman, and then, yes. Then
okay,
next.
okay,
Yeah.
it works now. Okay.
Yeah, okay.
Dr. Tariq explained the details of pathophysiology of the disease, so I will pass all of this because it takes time. The second question in the poll. And all of the following statements about pathology of NEC are true, except the necrosis may be patchy with skip areas of normal bowel. All of them answered 100% mucosal necrosis may occur without, no, there is change now. Yes, except A, of course. Let us go to the next question and the next. How to diagnose NEC? You have to do serial physical examination, laboratory investigations, abdominal X-rays, and ultrasonography, of course. You have to have high index of suspicion based on history and physical findings, as manifestations in the beginning is non-specific. Maybe it is due to alias or neonatal sepsis or something like this. And as we said, the age at diagnosis is inversely related to the gestational age and degree of prematurity. If the baby is younger than 30 weeks, so he will develop NEC later on, maybe after 2 weeks or something like this. If it is 31 to 33 weeks, within 2 weeks, full term, in the first week of life. Usually in the full term infants, the onset is sudden. There is sudden deterioration of the general condition of respiratory compensation, and there is shock, there is acidosis, a marked abdominal distension, and the blood culture is positive. But in the preterm infants, they have insidious onset, usually within 1 to 2 days, start to develop manifestations. There is food intolerance, there is a change in stool pattern, intermittent abdominal distension, there is occult blood in the stools. Then abdominal distension will appear in about 70 to 98%, and abdominal tenderness. There is emesis and increased aspiration from nasogastric tube about 70% of cases. There's occult blood in about 80 to 85% of cases, abdominal mass in 10, and the erythema of the abdominal wall in 10% also. And there is ascites associated with, of course, lethargy, apnea, respiratory stress, temperature instability, hypertension, acidosis, glucose instability, DIC, and positive blood cultures. So no specific manifestations can give you the clue. So we have to do investigation. But before investigations, what do you think? How to findings is indicative of significant bowel ischemia, increased gastric residuals, or septic shock, or cardiac failure due to patent ductus arteriosus, or elevated platelet count, or erythema of the abdominal wall. Although erythema of the abdominal wall is not a specific entity for NEC, but it is the most appropriate one for this question, of course. So we have to do radiology, searching for what? Searching for a lot of things like thickened distended bowel loops, pneumatosis intestinalis, pneumoperitoneum, portal venous gas, constant persistent fixed intestinal bowel loop. There is ascites or not, the thickening of the abdominal wall due to cellulitis. So as you see, plain X-ray shows there is a thickened loop with intramural gas and dilated loop, as you see. There is pneumatosis intestinalis, as Dr. Tariq explained. We have linear and cystic pattern. Linear usually in the muscularis and in the subserosa, but mucosal, submucosal one is the cystic type. And as you see, there's loops with pneumatosis intestinalis. Portal venous gas appears only in 30% of cases. So, and most of the authors considered it as transient sign. So, and if you don't find, don't search for it, because it will not help you in proper diagnosis. Here is portal venous gas, another X-ray showing portal venous gas. As you see, this is the dilated fixed loop, two different X-rays in 3 days, the same picture, almost the same picture, because we have dilated fixed loop, maybe due to ischemia and gangrene or distal obstruction. Pneumoperitoneum, it is very sensitive in about 40 to 50% of cases. And if you have pneumoperitoneum, this is end of the story, of course. For NEC pathology, you can see also here is pneumoperitoneum, another cross-table X-ray showing pneumoperitoneum. And as Dr. said, showed you there is scrotum air also. And here is the regular sign. You can see the intestinal wall between two spaces, two lucences, the free peritoneal air and the air inside the lumen of the intestine itself. And this is a football sign. Nowadays, we have doing ultrasound for cases of NEC, but the ultrasound has two problems. It is not available all the time, and it is operator dependent. But by ultrasound, we are searching for the bowel wall thickening, the focal fluid collections, pneumatosis, portal venous gas, and the changes in Doppler signaling for blood flow and the bowel mobility, gas bubbles in the hepatic parenchyma, pseudokidney sign, two echogenic lucences. And as you see, here is ultrasound. You can see thickened abdominal intestinal wall here, and there is pneumoperitoneum around. Duke University, they put criteria for radiology, what we call it DAS, Duke Abdominal Assessment Scale. This scale is 10-point radiographic scale, 0 normal gas pattern, 1 mild distension, 2 moderate distension, or normal with bubbly lucences that are like stool, focal moderate distension of bowel loops, separation of or focal thickening of the bowel loops, featureless or multiple separated bowel loops, possible pneumatosis with other abdominal findings, fixed or persistent dilatation of bowel loops, pneumatosis, portal venous gas, and pneumoperitoneum. And all the laboratory findings, no specific laboratory findings for NEC only suggestive, and it is a result of the drastic metabolic derangements that occurs because of this drastic disease. That's why we have what we call it metabolic derangement 7, MD7. They put this for risk adjustment in the outcome. MD7 includes positive blood culture, acidosis, pandemia, hyponatremia, thrombocytopenia, hypotension, and neutropenia. And of course, all of us know the staging of NEC, but bill staging depends mainly on the clinical findings and the radiological findings. And of course, a lot of findings in the neck, usually you can find in other diseases like spontaneous intestinal perforation or focal intestinal perforation. You can find in ileal atresia and Hirschsprung associated enterocolitis, in meconium ileus, in dissection sometimes, in volvulus. That's why Jordan and the co-workers tried to put classification, as you see, feeding intolerance of prematurity, neck and spontaneous intestinal perforation, and viral enteritis. As you see, a lot of things are common for all of these diseases. That's why we have a lot of works, but the result not good till now. So how to treat? Of course, if you have a case like this, you have to stop oral feeding, nasogastric decompression, antibiotics. Dr. Tariq mentioned the details, supportive measures, inotropes, control urine output, pain relief, repeated laboratory investigations, CBC, electrolytes, DIC panel and the blood gas every 6 to 8 hours, repeat X-rays, plain X-ray, of course, either left lateral decubitus or cross-table lateral view every 6 to 8 hours. And usually in the stage 1, there is marked improvement will occur, but stage 2, maybe it will go down to stage 1, improve, or go worse to stage 3 Bell classification, of course. So if there is improvement, so you have to continue medication 7 to 10 days after improvement. And if you have to go to surgery, you have to decide. You have to go to the surgery to, the only absolute indication for surgery is pneumoperitoneum. But the problem is, if you are waiting for the pneumoperitoneum, the patient will be in a bad condition. That's why if you have collection of relative indications like failure to improve, although you are doing medical management properly, or you have progressive thrombocytopenia or portal vein gas or severe arthritis or positive paracentesis or fixed dilated lobes, or there is erythema of the abdominal wall, all of these relative indications is a strong absolute indication for intervention. Don't wait for pneumoperitoneum. The question is, the absolute indication for surgery in neonatal necrotizing enterocolitis include, Amir? As you see, choice A is the highest score, of course, and it is the right choice. So you decided to do intervention. So if you have baby of weight 1,500 gram or less, so if he is stable, do for him laparotomy. If not stable, put peritoneal drainage, resuscitate properly. If there is improvement, most of the times, actually, we don't need to do laparotomy, but sometimes you have to do laparotomy, although patient is not improved properly. But if you have a baby of weight more than 1,500 gram, so go for laparotomy after resuscitation, of course. Dr. Albe mentioned the ways of peritoneal drainage. We are using Penrose drain or even finger of the glove. Sometimes we are using molecular catheter, DPZ catheter. And if you didn't find anything, you can use even Nelson catheter. Although it is tough, but better than nothing. Mostly you are putting either in the left or right iliac fossa. Sometimes you are putting in both sides. Rarely I use the think of catheter actually that we are using for peritoneal dialysis. Sometimes it is available, so I can use think of catheter even.
2 minutes, Professor Ayman.
Okay, I'm about to finish anyway. You have laparotomy, so either you have focal or multisegmental or pan-intestinal. As Dr. Augustine mentioned, either you are doing a stoma or doing primary anastomosis, which I don't like, or you have to do stoma or multiple stomas. Sometimes you have to do patch and drain and wait, or clip and drop back. Gangrenous intestine, focal, extensive perforations, clip and drop, as you see. Laparoscopy, I used the laparoscopy in one case only because of my assistant insisting to do, because I was afraid to do laparoscopy because of the metabolic derangement, and there is carbon dioxide, and there is respiratory embarrassment, a lot of things. I am afraid of it. And I think laparoscopy, like laser in vascular malformations, there was an era using vascular malformation laser, but now it is not using. And also laparoscopy in NEC, I don't recommend at all. How can we prevent breast milk? Antenatal steroids. There is era in Egypt now, they are using corticosteroids in the last 2 months of pregnancy to prevent occurrence of NEC. Be cautious in advancement of feeding. Probiotics is very important. They use ibuprofen instead of indomethacin for closure of patent ductus arteriosus. Prognosis, we have a lot of complications occurs in cases like this. I have to mention very quickly, we have 2 cases of stricture, mainly in the pelvic colon, as you see. Another patient was recurrent of neck, and another patient on the right was fecal fistula because of he has patent intestinal duct that appears only after he develops the stricture after NEC. After doing histogram, we found the stricture in the distal ileum. The last question. You are making rounds in the neonatal intensive care unit and discussing complications of necrotizing enterocolitis with reasons of the following. The most likely long-term complications following NEC is yes, intestinal stricture, and mostly in the colon, and specifically in the pelvic colon. This is the commonest site of stricture. I think in the future we have to concentrate on plasma MIR 1290 and marker also like calprotectin and fecal calprotectin and urine intestinal fatty acid binding protein and the probiotics. I think this will improve much the outcome of cases of NEC. Thanks a lot.
Thank you very much, Professor Ayman. Now we are ready to present some of the questions from our audience.
Good evening, everyone. I'm Adam Saeed. I've been collecting the questions from the audience. It's actually a pleasure, and we thank you all for giving these great talks. We also thank the scientific committee of EPSA for inviting the distinguished presenters that we had today. Our attendance reached 370 participants. When I've gathered half of the questions, the other half will be delivered by Dr. Tamer, our second moderator for this week. Our first question to Dr. Walili. you think that better health care presented in better neonatal care is an indirect cause of increased incidence of necrotizing enterocolitis? Dr. Walili, please unmute yourself.
Repeat the
Yes, Dr. Walili,
Yes.
Do you think that better health care presented in better neonatal care is an indirect cause of increased incidence of necrotizing enterocolitis?
To some extent, yes. To some extent, no. Because, you know, we have faced by a very huge number of low birth weight now, according to the IVF for obstetric procedure. So we have to prepare ourselves for such conditions by good anticipation for the problem and allowing the not aggressive eternal feeding in the form of formula, but try to encourage breast milk feeding or using the new formula with human milk oligosaccharides. Of course, this will solve a lot of problems.
The connection is Dr. Walili. Are you?
I couldn't hear you, Dr. Adham. Can you raise your voice out?
Yes, the role of fecal transplantation in treatment of NEC.
No, there is no role for the fecal transplantation. It depends on the cases of Clostridium difficile, but not in NEC. For the case of Clostridium difficile, there's a problem of the microbiota itself. So, in this condition, fecal transplant or microbiome transplant will help in cases of Clostridium difficile, but not on the neck. It's not studied.
How about hyperbaric oxygen? What do you feel about that?
I'm sorry, I don't read anything about that. I'm not tried it, so I don't know.
Okay, okay. You actually during the presentation you showed us a staging system. So there was a question from the participant saying, what does this staging system affect our decision on our practice or management?
Yes, that's at least starting by expecting or suspecting a case of NEC. So in case of suspected NEC, you have to follow. They start with parenteral antibiotics, stop feeding for a while, giving breast milk instead of formula, and follow up the cases. If it is proceed through the stages, you can just withhold the eternal feeding and give a chance for decompression by nasogastric tube and rectal tube, and follow up by the lab science. As soon as you search a condition of indication for surgery, you can refer immediately without hesitation. So that's the proper for good anticipation of going with the staging. The staging is a matter of discrimination between the type of cases. Is suspected or definite or severe, with complication, needs surgical intervention.
So, sir, in other words, you say that this staging gives us a good guideline for our management, so we can use it very well.
It's acceptable up till now, although it is raised up in the 70s, modified in 1969, but it's still working up till now without any chance to change it. As soon as we are going with more or less acceptable results, so we can proceed for the same staging while this is changed.
Sir, do you recommend the use of antibiotics in cases of NEC? And how do you do the choice of antibiotics? How do you choose the antibiotics given?
Yes, the choice of antibiotics here depends on the stage of PELS classification and on the condition itself. Of course, if you have suspected the Bacillus resistant Staph aureus in your nursery or in the previous cases, you can start by vancomycin, gentamicin. If it is with real affection, you have to go through the other line of management as Wactam. But in condition with not responding to amoxicillin, gentamicin in a definite case, you can add metronidazole as for the anaerobes. So the antibiotics here, it's a decision, but not prehand, because sometimes antibiotics will aggravate the condition due to disturbance, even if so it's parenteral and not oral, but interfere with the intestinal microbiome towards the pathological bacteria, and of course disarrangement or disruption of the microbiome causes this morphosis, and this condition will enhance the inflammatory process of the neck.
Thank you very much, sir. Your last question, please. How would you feel about the donor breast milk?
Yes, it is, although it's not available now in Egypt, but it's allowed outside, because here they are stuck to the breast milk due to the presence of human milk oligosaccharides, which is readily available, and the lactoferrin will enhance the anti-inflammatory for the breast milk itself. It's the best time, of course, to be the breast milk of the mother herself. But if there is a chance for a donor breast milk, they have to. And now they are preparing some types of formula where human milk oligosaccharides available using the probiotics and the manufacturing the probiotics to give a chance either added to with prebiotics to form a kind of symbiotics, although it's very difficult because it is a species specific to enhance the growth of microbiome inside the intestine, but it's highly recommended to use the breast milk even from a donor.
Thank you very much. Thank you, Professor. We have some questions for Professor Alp. Professor Alp, could you yes, Professor Alp? We really enjoyed your talk. Thank you very much. There are some questions from the floor. The first question is, what do you think about stem cells and treatment of NEC? Does it have a role?
Sorry, I couldn't hear the question. What do I think about?
Stem cells, the use of stem cells.
Stem cells?
Yes. Does stem cells have any role in treatment of NEC?
Well, I hope that it will have a role at some stage, but certainly there's nothing that is available at the moment, and it's not something that we have in our practice. As we have heard from other speakers as well, we've so much concentrated on the surgery and the different methods for NEC, but the answer really lies in the prevention and the medical management in the long term. So it will, it's a research field that it needs to be looked at, but it's not something that we have as a treatment modality that we can utilize at this stage in our practice, at least.
Professor Walili, you have a comment?
Yes. For this stem cell therapy, it's still promising in the future. It's done already on the experimental animal in the mice dogs, and it is given a good chance to enhance the progress of the intestinal microbiota toward the regulation of the repair process of the intestinal wall. So it is given a chance, but till now it's not well known everywhere. It's just experimental.
Thank you very much.
It's given intraperitoneal.
Yes. Professor Alp, is pneumoperitoneum an absolute indication for exploration?
Yeah, I think if there is pneumoperitoneum, one would regard surgery as the first option. There may be very, very few circumstances where the baby is so stable and everything is looking so well that perhaps putting a drain in might just be adequate. If you don't regard the drain or a intravenous cannula, and you may have just a bit, normal good outcome from that. But majority of the patients will have surgery.
Sir, you presented a picture of vacuum-assisted closure. What do you feel about the use of vacuum-assisted closure in NEC?
We use it extensively. So we've been, for the last 15 years or so, we are very much proponents of leaving the abdomen open and taking care with the intra-abdominal pressure. So if there's, not just for NEC, for other conditions as well, but certainly for NEC, if there's a damage control type procedure, if we're concerned about the intra-abdominal pressures, we would leave the abdomen open and go for a relook laparotomy. So part of that would involve putting a vac drain. It's partly because it absorbs all the effluent that comes out from the peritoneal space, and it keeps the abdominal wound clean, and also obviously removing all the potential the leaks from the gut.
Thank you, sir. Do you think that peritoneal drainage should be done bedside or in the theater? What do you
Oh,
think
we
about
do it. Yeah, we do it in the bedside. So, as I mentioned, we have to service neonatal units outside our hospital where there's no operating room facilities. But it's a very simple procedure. It can be done at the bedside, and you don't need to take the patient to theater, to operating room to put in a peritoneal drainage.
Okay, thank you. There's another question, please. When do you close the stoma? If you do a stoma, when do you close the stoma?
So 6 weeks is our main sort of time frame. Following the discharge of the patient, we do a contrast enema, make sure that there is no distal stricture, and close the stoma.
Okay, do you do
Depending on what stoma you've done, of course, and if you've done a very high jejunal stoma, then you may consider going in earlier. And then we also do quite a lot of distal feeding. So before we get to the stoma closure, if we have a very high jejunostomy or ileostomy with high losses, and we have access to the distal bowel, we would feed that bowel.
Okay, you do a distal contrast study. Do you also do a proximal contrast study or only distal? Or do you feel like
we would only do distal. Proximal one, stoma will declare itself if there's any obstruction or not. If the stoma is functioning well, we don't investigate it further before the closure.
Sir, do you have any parameters to anticipate the predisposition of a premature developing NEC?
Just repeat the question again. Do we have any parameters?
Parameters to anticipate the predisposition of a premature to acquire NEC.
No, I think it's mainly the prematurity and the feeding regime in the neonatal ICUs. The one thing one needs to be careful is you may see episodes of NEC coming from those neonatal units, which we certainly had. And you know, if the numbers increase, one needs to look into that. There may be a variety of things. And feeding regime is usually one of them, or other infectious potential problems might be around. So you know, one needs to be careful to the sudden increase in the numbers that you're receiving from neonatal units.
Thank you, sir. Last question for you. Do you use the ultrasound as a primary diagnostic modality?
No, ultrasound, we don't use it as a routine diagnostic modality. It's predominantly clinical and radiology in the form of X-rays. And we have used laparoscopy, as Juan also mentioned. So that's predominantly in the group where the decision whether this is a NEC or not is not there. And we've certainly, with laparoscopy, isolated patients that did not have necrotizing enterocolitis. I mean, in one case, it was chyle ascites, which without the laparoscopy, we wouldn't be able to notice that and diagnose that. So that's an area that really may have a impact in the future, particularly in that group that the diagnosis is not clear. But in terms of ultrasound, no, we don't routinely use that.
Thank you very much. I will hand over the other questions to Dr. Tamer. Dr. Tamer, please join us. Thank you.
Well, thank you, Dr. Adham. Thank you for all the professors. And I have a few questions for Dr. Juan de Castin. Actually, there's a lot of debate when to intervene and how. And when you add the item of laparoscopy, the debate is more. So do we have questions about are the indications and timing for intervention are the same for open and laparoscopic methods?
Hello. Yeah. As you know, happens in every center. The surgeons on duty are the ones who decide whether or not to use each method. If there are surgeons, especially they are young surgeons, trained in laparoscopy and and they have to decide whether or not to go for a laparotomy, and we really have this very available because we have the NICU only 20 meters from the OR and all the equipment. So it's really easy to do a bedside exploration by laparoscopy, introducing one small 3 or 5 millimeters lens and very small amount of gas. So it's the patients are sick, but we don't elect, we don't choose the sickest one, and we don't use the ones that are clearly pathological and you decide to go to the operating room. So I think there are quite a few cases with indication to do laparoscopy, quite a few.
Thank you. So another question about the post-operative improvement. When do you decide, or how clinically do you decide whether there is a good mucosal and GIT integrity?
Well, it's true. When we do laparotomy, most of the times when we perform an enterostomy, whether jejunostomy or ileostomy. So integrity, it's in the first days after operation is easily done by inspecting the ostomy itself. If you find a necrotic ileostomy, probably you will do a ileostomy or jejunostomy in a necrotic area, and you have to be very careful following very closely these patients because it could be necessary to revisit the ileostomy again if it is not working. So by visual inspection is the first thing. The second thing is most of the ostomies must be working in the first 24, 48 hours. If not, you have to suspect that something is happening there, and probably a second look operation must be done. And this can be done even at the bedside. That we usually do that. So it's inspection, the quality of the liquid that is coming from the ostomy also is very important. So when the intestinal peristalsis is resumed and normal appearing liquid is coming from the ostomy, I think this is the best way to decide that the integrity of the gastrointestinal tract is going on, no? and working.
Okay, and we have another question about the option of primary anastomosis. If you are doing a primary anastomosis, do you need a different or a special care in the post-operative period? And if you don't have a satisfactory neonatal care for the baby post-operatively, does that change your decision whether to do a stoma or an anastomosis?
Absolutely, absolutely. If we have the fortune to have a very good NICU faculty and nurses, and the quality of care allows you to take some risk at surgery, I think you can do it. But if you are not sure about the post-operative care, it's much more safer not to do any kind of anastomosis the first time.
Okay, another question related to that. If you do a high stoma, and do you have any experience with refeeding through the distal stoma? Do you do that routinely?
Yeah, absolutely. Yes, we have quite a lot of experience with that. It was working since a lot of years ago. We refeed the baby with their own liquid. It improves the integrity of the mucosa distally to the ostomy, and it can be done by taking the amount directly from the bag and with a pump easily to you don't need too much amount of that, just the amount to to facilitate the integrity of the distal bowel.
Okay, thanks. And we have a question from Dr. Sharif Shahada about the stoma closure. Do you need to do a proximal contrast study to the gut proximal to the stoma, or it's enough to do just a distal contrast?
I think if we most of the times we do only distally, but because the proximal stoma is working well. But if you have any doubt regarding to the presence of a stenosis of that you are not sure about that the bowel is working because you have a distal ostomy, I think it can be done. But most of the time we don't use it. We use the distal control one,
Okay,
even
so,
by enema, even.
Sure, thanks. And one last question. Is there a place for basic research to improve our clinical decision?
Well, yes, basic research for us is it's not very close. No, we like clinical research, and absolutely. There are many centers with basic research in England, in North America, in many countries that they have fellows doing a lot of basic research on NEC, especially in North America, no? But in Europe or our countries that surgeons we have to deal with more clinical work. We participate in clinical essays, in clinical works. We are now working with our neonatologists in the breastfeeding with very good results, and we almost diminished by 10% of the NEC rate in our hospital because of we improved the with a milk bank from mothers that from the same hospital. So we are seeing now very bad NECs, and most of them because they have congenital heart disease associated. But I think, yes, clinical research we like more than basic research.
Okay, thank you. Thank you so much for your question. Actually, the discussion can go on for hours. The topic is very debatable. And I need to move to Dr. Ayman for a few questions. Dr. Ayman?
Yes, Tamer.
We have a question about what is the difference in management between NEC and idiopathic bowel perforation?
Mostly idiopathic bowel perforation, general condition of the patient is better than patient of NEC. And usually it is just one perforation, mostly in the terminal ileum. So patient has general condition, just go to do laparotomy and you will excise or do trimming for this perforation and then do primary closure, everything will be okay. But on the other hand, in patient with NEC, usually there is a big segment affected by inflammation, and the general condition of the patient is not good. So it is a different entity, but single or idiopathic intestine perforation, as I said, patient is in a good condition and you go to do laparotomy, patient will improve very soon.
Okay, another question about your personal preference about whether to drain or to explore for a baby with a portal gas shadow and no pneumoperitoneum. Which do you prefer, drainage or exploration?
Yeah, you have only portal vein gas, or you have a lot of signs like fixed dilated loop.
Actually, the question is not clear, but I guess do you have to wait for like frank indications for pneumoperitoneum, or when do you put drain?
In a situation like this, I will put drain only. Okay. If patient improves, it's okay. If he is deteriorating, I have to go to do laparotomy.
So there is no harm in trying and drain first if there is no clear indication for exploration, right?
Of course.
Okay. And another related question about how to differentiate between the pathway of drain only and to go for laparotomy after inserting a drain. It's a clear criteria for that. Actually, we have talked about that, but can you give like a short indication?
If you put a percutaneous drain in a patient, you will observe the outcome, the general condition of the patient, the lab investigations of the patient, and the X-rays. If there is improvement in X-rays, there is no more pneumoperitoneum, no more ascites, no more thickening of the intestinal loops, and also improvement of the metabolic derangements that present in the lab investigations, and the general condition improves, so you can continue in this drainage. If there is deterioration of all of these, you have to do laparotomy.
Okay. Another question about like suspected cases. Is there a routine investigations and follow-up schedule that you have as a standard for these patients?
At least do plain X-rays every 12 hours. And if you have a chance to do ultrasound, it will be good aid for plain X-ray, besides lab investigations, of course, and the clinical observation of the patient condition.
And if they're like, how long would you wait to tell that this baby is not a suspect anymore?
I think a neonatologist will tell us.
Okay. There is another question about the DO classification. Is there a place for the DO classification now?
It is sophisticated, actually. You see, it is 10 points, no clear definitions, no clear limits between the 10 points, but it's okay. It will help you to follow the patient, okay? You can use beside the bill classification, so it will help. Why not?
Okay, we have another question about the C-reactive protein. What is the place for it in your surgical decision making?
C-reactive protein is not specific for this problem. It is one of the acute phase reactant for infection and for injury, of course. So you will follow if this C-reactive protein is increasing, besides other things I mentioned before. So it is one of the parameters you can use. If there is increasing in the level of the C-reactive protein, either with quantitative method, of course, so you can consider him one of the measures you can measure for detection, either to do intervention or to continue medical treatment.
Okay, one last question about the duration of MPO post-operatively. Is there a fixed MPO duration post-operatively, or you go with the on a clinical basis?
You mean after primary anastomosis or after stoma formation? It differs.
Well, I assume you can answer both scenarios.
Okay, if you have a stoma, you will wait till the stoma is functioning properly, and there is improvement in general condition. You can start oral feeding. You can start trophic feeding, and then you can increase gradually till you reach to the full feeding. If you have primary anastomosis, so you will observe the gastric residuals, the abdominal distension, the passage of stools, and so on. So classically speaking, we are waiting for 5 days, but it depends upon the clinical condition of the patient.
Well, actually, this was the last question, and I would like to pass this question to Dr. Tariq. Sorry, Dr. Adham.
One more question, please, for the floor, for all the speakers. You have any experience with the use of T-tube? The use of T-tube, if you're doing the resection and anastomosis, do you use a proximal T-tube in any of the cases?
I have experience in two cases.
You have done that in 2 cases?
In 2 cases, Adham. One case, I put just a tube as like a bridge, not T-tube.
Yes.
It works good, but patient unfortunately died due to aspiration.
Kwan, do you have any experience with that, please?
No, with T-tubes, no. We have used stents for when there is multiple perforation and you have a short bowel, and stenting the bowel with a tube and doing the small stitches to try to the bowel to to do spontaneous anastomosis and try to preserve as much bowel as possible, but not T-tube as that.
Yeah, but you use the stent.
Yes,
Same thing.
sometimes.
Dr. Al?
Yeah, so we don't have experience using T-tube as a proximal diversion to protect an anastomosis, but we have used T-tube numerous settings when there is a leaking anastomosis and you want to contain the leak either following NEC or other conditions, and so that's certainly been helpful to us. I must say it's becoming more and more difficult to find T-tubes these days, and because the general surgeons are not using it anymore.
Yes.
But it has a role to play, and we hide one somewhere, usually in the theaters.
Adham, may I comment?
Yes, please. Yes, please.
Well, there has been a few publications about the use of YouTube, and I think it makes good sense when you are thinking between making a stoma or primary anastomosis. Probably this is a time to put a T-tube, because it gives you both benefits. It gives you a temporary diversion if you are worried about the anastomosis or about the integrity of the bowel below. And when everything is okay, you can give a contrast study, see everything is okay. If it is okay, you pull it out and you don't have to close the stoma. There is, I'm aware of publications from Sudan, Dr. Abdel Basit Ali, and from Egypt, Dr. Assam Al-Halabi. I personally have some small number of cases, and I think in a difficult intestinal atresia or NEC, when you are thinking between making a stoma or primary resection, probably this is the time to try T-tube.
Dr. Kamel, go on, please.
Actually, I wanted to ask Dr. Tariq about the regular debate between surgeons and neonatologists about when to start feeding and the feeding regimen. Surgeons tends to rush a bit more and not sticking to the fixed feeding regimen for premature babies. So when it comes to post-operative establishment of feeding, what do you think about the proper regimen we should adopt?
Yes, it depends upon the duration of antibiotics. The guidelines usually join use of antibiotics duration with the duration of the NBO. So if you're still on antibiotic, you have to be completely on NBO. Sometimes you give a chance about 3 to 5 days after full improvement to start just bistrophic feedings, and gradually with breast milk or breast milk components. Secondly, by high formula, or especially for premature formula, not regular formula. So it's not debatable as soon as we are just using antibiotic properly according to the guidelines, and line by line or parallel, you have to stop feeding and return back to feeds after switch antibiotics or after complete clinic improvement, at least by 3 days.
And the same question for early stage NEC or suspected patients to have NEC.
Yes.
We go into MPO, and the question is when to start, restart feeding, and which ways, which regimen.
In a suspected case, you have to consider the risk factors. The prematurity, the low birth weight or the extremely low birth weight, the previous use of antibiotics, or the type of food associated, some sort of genetic predisposition. So you have to consider the risk factors first. If it's justified with you, all the things, especially those with susceptible to hypoxia, especially those with congenital heart disease, as a case of PDA, we start to use ibuprofen or even acetaminophen to close the beta ductal cirrhosis in a small preterm to help or give a chance for good perfusion of the intestine before starting feeding. So we have to depend on TBN for a while, especially those post-operative. Post-operative, we have to go to TBN for a while at least when the clinical improvement and of course by the biomarkers, if it is available, or acute inflammatory acute phase reactants, such as the C-reactive protein.
At the end of the day, it needs a lot of clinical experience to decide what to do, as it's sometimes confusing. Actually, most of the time it's confusing. Okay,
Yes,
thank you,
it's
Dr.
still controversy up to now, but every school has its own regimen. Even the feeding or the antibiotic use, we have to follow the international guidelines, but we have to suit or to tailor the regimen according to the requirement of your NICU.
Okay, thank you, Dr.
Thank you so much.
Tamer, maybe we can allow a few people are raising their hands.
Yes.
We can allow, yeah.
Dr. Sameh, we have Dr. Gamal Saeed and Dr. Munzir Haddad. They want to give comments. Tamer, please unmute them.
Quick questions and quick answers, please. We have 10 minutes.
Dr. Gamal, would you please unmute yourself?
Yeah.
Dr. Gamal, please unmute yourself. Yes, Dr. Gamal.
Assalamu alaikum. Thank you for all speaker for this rich scientific meeting. I have some question to any of the speakers to the floor because of there is what is called terminology, what is NEC paradox. Can you highlight for this is for the audience what is NEC paradox? Number two is usually we are seeing a pneumoperitoneum in a ventilated baby without clear external signs for the neck. How can we differentiate this leakage from the mediastinum, barotrauma, or from the bowel perforation? Third, Dr. Ayman mentioned that it's the most common site of structure formation in the distal colon. In spite of the most of the inflammation of the bowel in the neck occurs usually in the distal area. How can we explain this? Thank you very much.
So the question is about NEC paradox. Can any of our professors tell us about that?
NEC paradox is usually accompanied by the recurrence of the condition, but it's not common to be seen, especially the outcome, the high mortality was very extensively poorly portrayed. Will not get a chance for recurrence. Sometimes these cases may recur, or if it is treated early with not breastfeeding, with this sustainable cause of hypoxia, so they get a paradox. Or it's not now medical, it's can turn into a surgical problem later on. What is the second question is?
Actually, I couldn't get the second question. Dr. Gamal, are you still with us? Would you please repeat the second question?
There is usually there is
ventilator pneumoperitoneum.
Yes, with the ventilator, it's usually the pneumothorax first. So it's an emergency in the newborn unit. If a patient on ventilation, it becomes on pneumothorax. Till reaching pneumoperitoneum, it will be a very complicated condition. So we don't see in a ventilated process for a respiratory problem, we could see pneumoperitoneum. But for a case of a very small preterm associated with antibiotic intake or high risk factors as congenital anomalies of the heart, as BTA, so we can expect both of them, but with NEC, not with respiratory problems.
Yeah, to find pneumoperitoneum for us, we say it's a very strong indication for surgery. Yes, even we cannot find perforation, but I think it's better to have do a laparotomy or laparoscopy sometimes if you can. But I think pneumoperitoneum in the absence of pneumothorax or pneumomediastinum, it's a strong suspicion of bowel perforation.
That's right. If it's a spontaneous intestinal perforation, it comes, but not with respiratory problems. So a ventilated patient for a chest problem, not expected to have pneumoperitoneum. But for this very small return with neglected conditions, we can expect both together. Respiratory associated with NEC on the same time.
Okay, thank you, doctors. Dr. Khalid, are you with us?
I'm with you. And I would like to raise a question, please, concerning the new peritoneum. When babies were unventilated with CPAP, and I've noticed quite a lot of new cases of pneumoperitoneums associated with CPAP, and they're usually not related to a neck condition.
Maybe
mostly
perforation.
Or they have pneumomediastinum, Khalid. I saw a lot of cases like this. Pneumomediastinum followed by pneumoperitoneum.
That's
okay. Ventilated patients.
Yes. But without pneumothorax.
Yes, yes, Dr. Tari. In situation like this, I'm putting percutaneous drain, peritoneal drain, and then observe the patient condition. If he's improving, it's okay. If not, I have to do surgery.
Okay.
I think Dr. Munzer Haddad has a question. Yes, please, Dr. Munzer.
Hello, good evening, and thanks everybody for such a very good seminar. This raises a lot of questions, but my main question to the surgical presenters, Alp, Juan, and Ayman. We've seen the variability of the presentation of necrotizing enterocolitis, and also there is no yet evidence-based management surgically that we can do to actually improve the outcome so far. Do you think that there is a way to standardize according to the operative findings, whether through laparoscopy or laparotomy, to actually have a procedure to improve the outcome? And I mean, because nowadays, even in my hospital, different surgeons do different approaches. In London, different sort of hospitals do different approaches. So is there a way, or what do you think there will be a way to standardize the procedures according to the operative findings?
Difficult question.
You know, because all of us, I mean, have been working in this. I mean, I've been sort of dealing with necrotizing enterocolitis for the last 30 years. But the thing is, every time we go through something, you do something different. But is there a way to actually standardize that with an sort of evidence-based randomized control study, prescription of what the operative findings are global-wise or nation-wise and then global-wise?
I'm sure we can. And I think from the WOFAPS Society, you can do many things about that because you have a very well-structured guidelines. And I think it's necessary to have guidelines. It's very clear for the extreme parts of the spectrum, no? But the difficult ones is the one that is difficult to take a decision whether or not to do resection, proximal ostomy, distal ostomy, etc. So, but I think something must be done, and are the scientific societies that are responsible to do that.
Yeah, that's why I'm asking the question whether any of the other societies, because I'm bringing that as a project for the WOFAPS. But
Dr. Munzer, excuse me.
Yeah.
As Juan said a few minutes ago, he said the one who is taking a decision for intervention for neck usually junior staff. This is one thing. So the experience of the surgeon, this is one factor. The other factor is the condition of the neonatologist and the condition of the patient. So you cannot standardize all of this.
Well, that's my question. Why don't we actually try to standardize? Because as you said, a lot of the surgeons are the junior surgeons, which they don't have the experience. And why don't we guide them in a certain way according to the findings? It's our responsibility in a way to guide them.
What about the neonatologist and the condition of the patient? This is variable.
Yeah, I very much agree with Munter. I mean, I think you really identified the issue very well, and we have to have some sort of guidelines established that is shared by different units.
Yeah.
Perhaps, as Juan mentioned, there's certain regions that this can be done with a bit more ease, and the UK is maybe one of them, and maybe Holland is another one, and there must be others as well. And there's certain areas that is more difficult to bring that collaboration, but it's an everyday occurrence. And even in our own hospital setting on Sunday evening, an NEC came in not in a shape to have an operation with a pH of 6.9, and we were asked to operate on the patient because the colleagues from neonatology wants to see what is the status of the bowel, that they can make a decision whether to withdraw or not. So there are, even in one hospital, different surgeons, different physicians have different opinions, and without having some sort of a standard, there's no way we will be able to come up with solutions to say this method is perhaps slightly better than the other one. And I agree with you, absolutely.
Thank you. Thank you. Well, thank you very much for all the speakers, and interesting.
Thank you, Manzi. Dr. Hussein will follow up with,
Dr. Ahmed Khairi has been raising his hand for some time now. Dr. Ahmed, can you please unmute yourself? Dr. Ahmed Khairi, are you still with us? Yes, thank you, please.
Assalamu alaikum. First of all, I would like to thank all of you for this very enriching presentations. Actually, I have two small comments I'd like to consider. Regarding the next aspect, when we are dealing with a patient who is not clear-cut, surgically needs surgery and surgical intervention, or shall continue conservative, I find very important test that we can rely before starting oral feeding is the occult blood in stool. So I wouldn't recommend to start oral feeding for any baby who has been NEC suspect, even if it's improving clinically, unless you make occult blood, make sure it is negative occult blood in stool. The other comment is the portal vein air.
Stations is occult blood in stool.
Yeah, occult blood in stool is very important before starting oral feeding for any NEC suspect patient.
Yes.
The other thing is the portal vein air.
Yeah.
This is a temporary sign, and per se it does not mean anything unless it is associated with other clinical signs of the many signs and symptoms of NEC. But if you just find portal vein air like that, this is not an indication for drain or whatever. You just had to be put in the context of the other clinical situation of the baby. My last comment is regarding that, we are all talking, especially we have a lot of junior staff with us here now. We are talking about NEC in the preterm and the baby with RDS and everything else. But we should not forget that NEC happens sometimes in post-operative cases, especially, for example, cases of abdominal wall defects. So if you repair omphalocele or gastroschisis, a very big percentage of these cases develop NEC. And unfortunately, many neonatologists or doctors are not aware of this complication. It could happen. So we have to make stress on that. NEC is not only a disease of preterm or premature babies or low birth weight like that. Sometimes NEC happens in the post-operative patients, like repairing omphalocele, repairing gastroschisis, and sometimes it's a cause of mortality. You do a very good success for repair, and the patient start oral, and after 1 week, it start to get distended and erythema, and we lost patient for that. And thank you very much for that. Thank you.
Thank you very much, Dr.
Excuse me, you can expect NEC even a full term with any condition impairment of the gastrointestinal microcirculation. So interfering with the abdominal surgery, looking for the perfusion of the intestine is very crucial to discriminate between susceptibility to NEC or not. So I agree with you that some conditions with abdominal surgery may be susceptible to NEC rather than prematurity alone.
That's
right. Dr. Khaled Sharif.
Good evening. Can you hear me, please?
Yes, we can hear you.
First of all, thank you for all presenters for this great effort. I'd like to there is a very special debate about what's called the NEST trial, Necrotizing enterocolitis surgical trial. It's a big trial that was done in Europe. And actually, they have concluded that it's a very big trial. They concluded that as long as short-term follow-up, the morbidity and mortality for the drain versus surgical resection is the same. However, it's very important that on the long-term follow-up, after 1 year or 2 years, they noticed that the neurological impairment for those who were treated by drain is much more higher than for those who were treated by surgery. So I think that the drain is an easy solution. It's rapid, of course. That's why it's plausible. However, according to this trial, we have to think again and again about the role of surgery. And you have to consider that the drain is just a bridge for those who are not fit for operation. Do you agree or not? This is number one. My question is about the refeeding succus enterics. Sometimes when you have very high stoma and this patient cannot tolerate closure because he did not gain weight, what about the use of the concept of refeeding succus entericus? Do you comment or you don't? Thank you very much.
If I may comment about the peritoneal drainage and neurological impairment that follows it. So we also use the peritoneal drainage as part of the resuscitation. And it's not in majority of the cases, when I say majority, it's 98%, 99% of the cases. It's not a definitive treatment. It's just a bridge and helps with the sort of slight improvement for transfer, resuscitation, and for surgery. Perhaps the reason why they're seeing high neurological impairment is because that's the group of patients that are sick to start with, that are not fit for a laparotomy. And that might be the reason, but of course that needs to be investigated further. Refeeding, we use that often, and it's, as other speakers also mentioned, that it's certainly beneficial, particularly if you have a high stoma, in terms of the stoma losses, that you can put them back into the system again. And it's very beneficial towards making sure that the distal gut adapts and remains in a good shape before you close the stoma. So we would support that as well. Thanks.
I completely agree. I think that drainage is a temporary measure. When we saw the results from Toronto as a definitive treatment in small babies, and we started to do it in some small babies, we saw an unfavorable outcome, and so we returned back to the concept that the drainage is a bridge to stabilize the patients that are the most sickest patients, and so they are resuscitated, and these things has to be thought as also responsible for a worse outcome in the neurologically system.
Okay, last comment from Dr. Rafiq Shalabi.
Dr. Rafiq, would you please unmute? Dr. Rafiq, are you with us?
I don't have specific comments or questions, but I would like to say hello for my friend Professor Khwan and Al, and my dear friend Dr. Ayman and Dr. Salah. And I would like to thank all the speakers and the organizing committee, Dr. Sameh, Dr. Adham Saeed, and Dr. Tamer, and all the people of the EPSA board. And it is a very good idea. And thank you all.
Thank you so much.
Very much.
Thank you. Nice to see you.
I think now we can conclude our
So will you conclude, Dr. Khalid, before Dr. Sharif tells his last word?
Please go ahead, Dr. Sharif.
Aro, you are unmute me, please.
We can hear you, Dr. Sharif.
Okay, okay, thank you. First of all, I have to thank all the speakers on behalf of the EPSA. Gracias, Juan. Bedankt, Dr. Alp. And shukran, Dr. Tariq and Dr. Ayman. But I have one question regarding this point. Did anyone have experience in the fecal transplant and peritoneum in this management or no?
No, only
fecal
breastfeeding.
transplant is recommended in a case of NEC. It may be recommended for a case of Freudian difficile infection of the intestine, which is not so common in our community. It may be common in the States. To distort in Boston trials for on 20 patients for a fecal transplant of the younger age groups, and they can respond rather than use antibiotics instead. But in case of NEC, there is no role for fecal transplant, although it can be depends on the probiotic intake rather than the fecal transplant, because probiotic will modulate the microbiome of the gastrointestinal tract towards the commensal beneficial bacteria, so it can solve the problem to some extent or make a kind of prophylaxis against the progress of NEC, but not the fecal transplant.
I just read about it only, Sharif.
Yeah.
I would like to say that is feeding with the milk of a similar baby in age for the premise is very important. So even a small milliliters of milk from the same age baby, the mother's baby, is enough to maintain the microbiota control. And I think it's the future more than fecal transplantation.
Yes, even the ingredients of the breast milk, not rather it's not able to take his own mother breast. He can either use a donor or use the preparation of the ingredients, especially the human milk oligosaccharides, and of course the probiotics as a choice. And it's recommended by the American Academy of Pediatrics to be used as prophylaxis in case of NEC.
I think we come to the end of this meeting. Dr. Sharif, do you have any final word?
No, thank you for all, but you can give Dr. Khalid Hussein to conclude if he has any comments or something. Dr. Khalid.
Please conclude the session, Dr. Khalid.
Okay, it's been a pleasure and an honor to attend this wonderful and illuminating webinar. I would like to thank the EPSA for organizing it and Dr. Saad and Dr. Sharif for inviting me. I would like to thank our distinguished collaborators here, Dr. Tariq Al-Walili, Professor Juan, Dr. Aleppo, and my dear friend, Dr. Ayman. Thank you very much for your contribution today.
Thank you.
Thank you.
Thanks a lot for all of you. It's a very good chance. Yes.
Wait us every Wednesday at 9 p.m. Cairo local time. EPSA online meeting. Thank you.
Inshallah.
Thanks a lot. It's a very good chance to meet the pediatric surgeons away from the pediatricians. Thanks a lot. Thank you very much.
Thank you. Good night.
Thank you so much.
Good night, everybody. Thanks a lot.
Thank you so much.
كل سنة وأنتم طيبين.